had a previous surgery over here, which was fairly extensive, and then has since had a recurrence of the tumor sitting right back here. The problem with the mast cell tumor in this location, well, there are a couple of different things. Number one, it's fairly nebulous in its appearance, so it's hard to tell exactly where it is. So I'm just trying to outline it here. So that's what I believe to be the grossly visible tumor. And then we're going to have to get a margin around it of about 1 centimeter because it's a low-grade tumor. So usually with mast cell tumors, we can say about 1 centimeter per grade. And I am going to try to avoid exposing that calcaneus like that. Now the flap that we would use to close this is based on the reverse saphenous conduit, which is kind of up in this direction like this. So you go from the cranial surface of the tibia, come up, and then it's about 120 degrees around the leg. So that's what our axial pattern flap should look like. And the concern that I have is that it's possible that I'm going to damage that vessel as I'm coming around and excising the tumor. So if I do that, we're just going to have to leave it open to heal by second intention. I may take a little bit less out on that. Can you hold on to that, please, for me, Yui? And I'm going to come over and pump. Can you pump the table up for me a bit? Is that streaming? Is it? Okay. All right, so coming around the back here, just confirming if somebody can let us know that the stream is actually working. Can you click on the thing that looks like a thought bubble? Lower right, back one, yep, click on that. Go over, so slide it over some more. Slide the bottom over. Yeah. Yeah, okay. Is there a comment there that says that?
Yeah.
Yeah, okay. Is there a comment there that says that?
Yeah.
Everything's working?
Yeah.
All right, so just to reiterate, I've got a 2-year-old French Bulldog. We've got a recurrent mast cell tumor that was removed about 1 year ago. And so we're coming around and doing a wide local excision, and we are going to try to cure this thing. The axial pattern flap that we like to use in this location is called the reverse saphenous conduit. And the problem is that I may sacrifice the vessel as on this side.
And you say this was recurrent, Charles?
It is recurrent, yes. So if we look at this one, yeah, so it came down. So that's the extent of the incision right there. It's kind of at the tip of the incision. Coming around the front here. When I come around the front, that's when I'm going to ding the blood vessel, if I'm going to get it. And I'll try to avoid it if I can, but I'm more concerned about getting a clean margin than I am about preserving that vessel. But I know I can let it heal by second intention. But if I don't get a clean margin, it's kind of no point. And it's just a 2-year-old dog, and so it's going to have a long opportunity to recur. You know, we've got hopefully 12 or more years left in this dog's life. The question is, what do we do if we get an incomplete margin? Do we follow up with radiation therapy? Can I get another Metson Bomb scissor, please? This one's kind of gumming away. So I am trying to get a deep margin, and you can sacrifice the flexor tendons in this location without any effect on function if you need to. So it is not an easy location to get your excision. And this far peripheral, I'm not worried about nerves really, or vessels, honestly, as long as I keep a few vessels intact, you won't have an issue with necrosis. I'm a little bit concerned about that calcaneus because second intention healing certainly can be delayed over a bony prominence like that, if not ineffectual. Ewan is playing Twister with the dog.
For the guys at home, Charles, are you doing any loco-regional lymphadenectomy for low-grade mast cell tumors?
So Yui is asking if I'm doing any lymph node excision or mapping for low-grade mast cell tumors, and because the metastatic rate is low, my feeling is that we don't need to, but Ewan is kind of interested in lymph node mapping, and he may have some more up-to-date information that I'm not aware of. Do you know anything?
There's definitely information both ways.
Yeah.
More so for guided lymph node mapping versus loco-regional.
And that's with the low grade.
With low grade, yeah.
Right. And evidence that it's helpful?
Certainly evidence that it increased survival if there was increased survival in imaging, on imaging, no, and physical, no concerns for metastatic lymph node.
Yeah.
If they excised the lymph node based on loco-regional, they got METs in some of them.
Yeah. With low grade.
With low grade.
Right.
And in those that had loco-regional, lymphadenectomy had improved survival time.
Interesting. So I'll have to review that with Yui, because if there's evidence out there that suggests that I can be doing a better job, obviously I'm going to change the way I do things. So I'm just going right down onto the joint, hopefully removing joint capsule. And even taking a little bit of calcaneum tendon there. So I think this margin looks really good. Is it still on the field? Yep.
It says sound is not clear, maybe microphone not working?
Go back to the speaker there. And turn off HDMI1. Slide up the whole thing. Sorry, no, go back. Just slide the whole thing up. Yep, that's on. And then go back to the quote there. Yep. Let me know if the sound is any better. Just we were getting a double sound input from the camera and from the microphone, which when that happens, often we get an echo. So I'm sorry that you guys have not been getting the benefit of my great commentary.
Yeah, sounds clear now.
Okay. Everybody deserves the right to hear me talk.
You want a couple of questions, Charles?
Sure.
Did the dog have any treatment after the first surgery?
So it had, interestingly, it had histologically complete margins, and we had a recurrence anyway. So it recurred right at the tip. The issue with, so even though we had clean margins, this was done by another surgeon here who's an excellent surgeon, and because the margins were histologically complete, they elected not to pursue any further therapy. The problem with mast cell tumors is you can have what are called skip lesions, which means that you have mast cell, neoplastic mast cells existing outside of the tumor, not contiguous with the primary tumor. So no further adjuvant therapy was done after the surgery.
Is it still possible for the low-grade mast cell tumor
To metastasize? Yeah, so that's what Yui and I were just talking about. The question is it possible for a low-grade mast cell tumor to metastasize? And my perception was that with low-grade mast cell tumor, the risk of secondary spread is only about 5%. But Yui apparently has some...
It's still about 5%.
Okay. So I with low-grade mast cell tumors, I hardly even think about metastasis as an issue. So what's going on here? Is that tendon? I can feel a cord right here. So let's... You want to feel that, Yui? Right there. That lump right there. Do you want to feel that, Anita? I can't tell if it's tendon or tumor. It's very hard, so just pinch across there and you'll feel it slip between your fingers. Yeah, do you want to feel that, Millie? So as you pull it across, you feel like a little cord of tissue. And so the question is that a normal anatomical structure, or is that extension of the mast cell tumor? I don't know the answer to that at this point. And that's going to be our reverse saphenous conduit at the start of it right there. So I think that that's pretty much gone.
Should sail.
Yeah. These owners have been through, so that's the reverse saphenous conduit right there. So that's been sacrificed. And again, my first intent is to get a clean margin on this thing and deal with the healing later on. All right, so we've got this cord of tissue here, and I cannot tell what it is. It feels too defined to be a tumor extension. It's probably... Let's pull up on that, and I'll just dissect down on that a little bit.
Could you intra-operative cytology it?
You could. So Ewan was a little bit annoying with his great ideas because they take time. So Ewan is suggesting maybe intraoperative cytology to see if that's... I think that's a tendon.
I think that it's tendon, yeah.
Yeah. Yeah. Yeah, great. Okay, so just, yeah, you can see in cross-section that that's tendon there.
Do you get any loss of function of the tendon?
Not at all. So Anita's asking if we get any loss of function with tendon section. In this area, certainly not. There are tendons that you can't sacrifice, like the triceps tendon. You cannot sacrifice, so you'll run into problems. So that's the underside of the tumor. I feel really good about that, especially with that tendon sheath right there. I feel like that's a really good barrier to tumor extension. So now we've lost our reverse saphenous conduit, and I flip that. If I flip this over, you'll be able to see the vessels probably right there. So those are the vessels that supply the reverse saphenous conduit right there. And so we've lost that by removing the tumor. So now basically we're stuck with leaving this open to heal by second intention. But I feel really good about can you hold on to that? Really good about the excision that we've done, which was definitely not a sure thing when we started this surgery. So what I'd like to do is somehow get that skin to cover over the calcaneus. So can I get some 3.0 PDS, please? So what I'm going to do is I'm just going to suture the skin, kind of a hybrid suture, from the, so we'll bring that over the top here. So what I'm going to do is I'm going to suture to the joint capsule on one side and almost like an intradermal suture on the other side. Like that. And that will hopefully adhere down nicely. And I'm not going to try to close this, because when you go over the internal bending surface of the hock, you can very easily create a tourniquet effect where you could get at least swelling and up to possibly even necrosis of the distal extremity. So we're just going to be really careful with that. So I'm just going to grab onto the joint capsule here. And the joint capsule is a really robust structure, and so that's going to provide a really good anchor for this skin to come over that calcaneus. And I'm not particularly concerned about this hollow here. That'll just fill in with granulation tissue. So you can see how I'm getting a nice little cap of skin over the calcaneus. Structure is that right there? That's just another tendinous structure. And if you were a human foot surgeon, you would know every single tendon, nerve, vessel in this area. Because I don't operate on this area that frequently, and because those structures are not vital for function, you kind of, if you don't use it, you lose it. And so I would have known all of these when I studied for my surgery exams, but because I don't use them very frequently, I don't necessarily remember them. See if I can get that. That's not going to move at all. That's not going to move at all. That'll come together nicely. So let's get another bite of yeah. Yeah, that's good. That's okay. We might even put it in a splint that has a little bit of extension. Yui would know all about that since he ruptured his Achilles tendon about 12 weeks ago? No, more than that.
Just over 3 months ago.
Yeah. Silly boy. And he's had surgery for that and just got the all clear to go snowboarding.
Again.
Yeah.
Which is how I did it.
Yeah. All right. So, so we'll have that in extension, so it's not putting out tension on that skin. Yeah. And so Yui, let's just get a few more intradermal sutures here. We'll leave that alone. You can bring that across a little bit, but not too far.
A little buried one.
Yeah. All right. So I'll come over and make sure there aren't any questions that I haven't answered. So there's a question: if radiotherapy is not available and there's an incomplete margin, would you consider vincristine or palladia? Look, there's no evidence for the use of systemic chemotherapy to prevent recurrence of mast cell tumors. That's in contrast to soft tissue sarcomas, where there is evidence that metronomic chemotherapy will prevent local recurrence. So if you had no other choice, that would be a something that wouldn't be crazy to do, but I just don't know that there's a lot of evidence to support it. There's a question, any long-term biting or chewing issues related to granulation healing? So we'll keep that bandage, and we'll also keep an Elizabethan collar. If you left that open, then certainly that would be a risk. So if the lymph node shows metastasis, the histopathology might change the grading. So no, grading is purely a histological determination based on the appearance of the primary tumor. What you're talking about is staging. So staging would change with the lymph node metastasis, but not the grade of the tumor. Let's see. So the question is, why am I doing the recipient site first in this case? And that's an excellent question. The reason why you're asking that is that if I did harvest a flap and my margins on my primary surgery were dirty, then the flap would be contaminated. The reason why, and so ideally you should harvest the flap first if there's any question about your ability to get a clean margin. In this case, I just was very concerned about my ability to use that flap at all because of damage to the reverse saphenous conduit. So that's why I harvested the recipient site first. All right, so look, that's pretty much it. So that's an interesting case today that had a little bit of a challenge as far as reconstruction is concerned because of damage to that reverse saphenous conduit. We are going to do some minor primary closure, although we don't want to do anything major. And then also to keep that skin from elevating off the palmar surface, we are going to put an extension splint on that leg. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And Piyush is asking if we are going to do any more live streams today. I honestly can't remember what else I have today, to be honest with you. Hold on just a second. So we've got a dog with a probable foreign body in the nose, so I will not be streaming that. I've got a dog that has probably a septic arthritis, and so I won't be streaming that. And I think that that's about it. So likely not streaming anything more today, but if we get any emergencies or one of these other cases becomes surgical, then I'll do my best to live stream it. So great to see everybody today, and we'll see